Dear students, in the last two classes we were discussing about the care of patient on mechanical ventilator. We have finished the mechanical ventilator definition, types, history and also endotracheal intubation. Today we will continue with the same topic, that is care of patient on mechanical ventilator. How mechanical ventilators are classified. First one is according to control, that is how the ventilator knows how much flow to deliver. Three types are there, that is volume controlled ventilators, pressure controlled ventilators and dual controlled ventilators. What are volume controlled ventilators? Here volume is limited or volume targeted and pressure variable. Then the second one is pressure controlled. Pressure is limited or targeted and volume is variable. In dual controlled, volume targeted and pressure limited ventilators are also there. Then the second one is cycling. How the ventilator switches from inspiration to expiration. That is what is meant by cycling. It may be time cycled, flow cycled, volume cycled or pressure cycled ventilators. Time cycled ventilators is terminated to the expiratory phase once a predetermined inspiratory time elapses. It is usually used for neonates and in the operating room. So time cycled means the time will be set, and as the time is the set time is reached, the ventilator is terminated, that or the inspiratory phase is terminated and it switches to expiratory phase. Next one is the flow cycled. When the flow reaches to a predetermined level, the ventilator cycles from inspiration to expiration irrespective of inspiratory time or the tidal volume. Have pressure and flow sensors. Then pressure cycled ventilators terminate into the expiratory phase when airway pressure reaches to the predetermined level irrespective of tidal volume, inspiratory time and inspiratory flow rate. Pressure cycled ventilators are generally most useful for short-term use only. That is in case of transportation of a patient, and also it can be used at home or in rehabilitation centers. So these are the three types. Then one more, that is volume cycled ventilators. It is terminated or the inspiratory phase is terminated when a preset volume is delivered to the patient. Many adult ventilators are volume cycled, and these volume cycled ventilators are commonly used in hospitals, but also have secondary limits of inspiratory pressure to guard against pulmonary barotrauma. That's a complication of mechanical ventilation, damage to the or fracture of the alveoli. That will study in complications. So here the ventilators are volume cycled, that means the tidal volume is preset, and along with that the pressure limit also will be set, and when if the pressure limit is reached, then the inspiratory phase switches to expiratory phase even if volume is not delivered to the patient. That is, the preset tidal volume is not delivered to the patient. Okay, so in volume cycled ventilators, the preset volume, that is tidal volume, is delivered to the patient. Along with that, pressure limit also will be set. If the pressure limit reaches to set pressure reaches to the limit before the volume is delivered to the patient, in that case also volume will set tidal volume will not be given to the patient. Instead, the ventilator switches to expiratory phase. Okay, clear? അതായത് നമ്മളൊരു ടൈഡൽ വോളിയം സെറ്റ് ചെയ്യും. ആ ടൈഡൽ വോളിയം ആ ഒരു ലെവലിൽ ടൈഡൽ വോളിയം പ്രഷർ കൂട്ടാതിരിക്കാൻ വേണ്ടി, ആൽവിയോളയ്ക്ക് ഇഞ്ചുറി ഉണ്ടാക്കാതിരിക്കാൻ വേണ്ടി ഒരു പ്രഷർ ലിമിറ്റും സെറ്റ് ചെയ്തിട്ടുണ്ടാവും. ടൈഡൽ വോളിയം ഫുള്ളായിട്ട് ഡെലിവറി ചെയ്ത് കഴിയുമ്പോഴും ഈ വെന്റിലേറ്റർ ഇൻസ്പിറേഷൻ ഫേസിൽ നിന്നും എക്സ്പിറേറ്ററി ഫേസിലേക്ക് മാറും. അതുപോലെ തന്നെ ടൈഡൽ വോളിയം കംപ്ലീറ്റ് ആയിട്ട് ഡെലിവറി ചെയ്യുന്നതിന് മുമ്പ് തന്നെ പ്രഷർ ലിമിറ്റ് സെറ്റ് ചെയ്തത് എത്തുകയാണെങ്കിൽ, ആ ലിമിറ്റിലേക്ക് എത്തുകയാണെങ്കിൽ the ventilator will switch from inspiratory phase to expiratory phase. Then the third one is triggering. It can be that is what causes the ventilator to cycle to inspiration. അതായത് ഇൻസ്പിരേഷൻ സ്റ്റാർട്ട് ചെയ്യാനുള്ള ട്രിഗറിങ് ഫാക്ടർ എന്താണ്? It may be time, pressure or flow. The time means the ventilator cycles at a set frequency as determined by a controlled rate. Second one is the pressure. The ventilator sends the patient's inspiratory effort by way of a decrease in the baseline pressure. And the third one is flow. That is, modern ventilators deliver a constant flow around the circuit throughout the respiratory cycle. A deflection in this flow by patient inspiration is monitored by the ventilator and it delivers a breath. Requires less work by the patient than pressure triggering. Then we will see ventilation strategies. It can be assisted spontaneous breathing. That is, the ventilator provides only assistance to the patient. That is continuous positive airway pressure, which is known as CPAP. Then positive end expiratory pressure, that is PEEP. Then the second one is supported spontaneous breathing. That is pressure or volume support in spontaneous breathing. In the first one, only the assistance is given. In the second one, it can be spontaneous breathing can be supported. That is pressure support ventilation and volume support ventilation. Then mixed respiratory support, that is intermittent mandatory ventilation, synchronized intermittent mandatory ventilation. Then the fourth one is controlled mechanical ventilation, which the four modes are pressure controlled ventilation, volume controlled ventilation, controlled ventilation and high frequency ventilation. These are the ventilatory modes. We will come to that. Modes of mechanical ventilation. Modes of mechanical ventilation are described by the relationship between the various types of breath and by the variables that can occur during the inspiratory phase of ventilation. Each mode of ventilation is distinguished by how it initiates a breath. That is, it may be by a trigger, or how it sustains a breath, that is the limit, and how it terminates a breath, that is cycles. These are referred to as phase variables. ഇപ്പോൾ ഈ മോഡ്സ് എന്ന് പറയുന്നത് എങ്ങനെയാണ് പേഷ്യൻറ്റും വെൻറ്റിലേറ്ററും തമ്മിലുള്ള റിലേഷൻഷിപ്പ്, അതായത് എങ്ങനെയാണ് പേഷ്യൻറ്റിന് ഈ വെൻറ്റിലേറ്റർ ബ്രെത്ത് ഡെലിവർ ചെയ്യുന്നത്, അതാണ് മോഡ്സ് ഓഫ് മെക്കാനിക്കൽ വെൻറ്റിലേഷൻ. The basic modes of ventilation we will see. That is, first one is continuous mandatory ventilation, which is represented as a CMV. And second one is assist controlled ventilation, that is ACV. Then intermittent mandatory ventilation and positive end expiratory pressure, continuous positive airway pressure, and along with this SIMV also, synchronized intermittent mandatory ventilation. We'll see each one. First one is continuous mandatory ventilation, that is CMV. CMV completely controls the patient's ventilation. The ventilator provides a mechanical breath on a preset timing. Patient respiratory efforts are ignored in this mode. This is generally uncomfortable for children and adults who are conscious and is usually only used in an unconscious patient. In this mode, the ventilator delivers a mechanical breath with the preset volumes at a preset rate and preset flow rate. The patient cannot generate spontaneous breaths, volumes or flow rates in this mode. That is, patient is totally dependent on the mechanical ventilator. Mechanical ventilator controls each breath. In this mode, the tidal volume will be set, then there will be a preset rate and a preset flow rate. അപ്പോൾ നമ്മൾ സെറ്റ് ചെയ്തിരിക്കുന്ന വോളിയം അറ്റ് സെറ്റ് റേറ്റ് അറ്റ് എ പ്രീസെറ്റ് ഫ്ലോ റേറ്റ് വിൽ ബി ഡെലിവേർഡ് ടു ദ patient. The total control of the breath will be on the ventilator. The patient's effort is not at all considered in this CMV mode. You can see the diagrammatic representation. That is, first is the volume, then flow and pressure. All these are preset, and a preset volume at a preset flow rate at a set respiratory rate will be delivered to the patient. Then the disadvantage of this CMV mode. The major disadvantage is that it is not synchronized with the effort of the patient. When the patient is out of synchrony with the ventilator, he attempts to exhale as the ventilator is in inspiratory phase. As a result, airway pressure builds to abnormally high levels and the remainder of the inspiratory volume is not delivered. This bucking causes a high pressure alarm. So the disadvantage means the patient's effort is not counted here. പേഷ്യൻ്റ് ഒരു എഫേർട്ട് എടുക്കുകയാണെങ്കിൽ അത് വെൻറ്റിലേറ്റർ സെൻസ് ചെയ്യില്ല, അതിനനുസരിച്ച് വെൻറ്റിലേറ്ററിൽ ഒരു ചേഞ്ചും ഉണ്ടാവില്ല. അപ്പോൾ അവിടെ ഒരു അസിൻക്രോണി ഡെവലപ്പ് ചെയ്യും, വെൻറ്റിലേറ്റർ പേഷ്യൻ്റ് ഫൈറ്റ് ഡെവലപ്പ് ചെയ്യും. Here, if the patient takes an effort, he attempts to exhale as the ventilator gives inspiratory or the ventilator is in inspiratory phase. അതായത് വെൻറ്റിലേറ്റർ ഇൻസ്പിറേറ്ററി ഫേസിലുള്ള സമയത്ത് പേഷ്യൻ്റ് ഓൺ എഫേർട്ടിൽ എക്സെയിൽ ചെയ്യുകയാണെങ്കിൽ ആ എയർവേ പ്രഷർ ഇൻക്രീസ് ചെയ്യും. പേഷ്യൻ്റ് എക്സെയിൽ ചെയ്യുന്നു, വെൻറ്റിലേറ്റർ കൊടുക്കുന്നു, ബ്രത്ത് ഇൻസ്പിറേറ്ററി ഫേസിലാണ്, ഉള്ളിലേക്ക് ബ്രത്ത് കൊടുക്കുന്നു. അപ്പോൾ ആ ഒരു കണ്ടീഷനിൽ the pressure of the airway pressure will be increased and the ventilator gives a alarm. അപ്പോൾ ഇൻസ്പിറേറ്ററി ഫേസിലുള്ള വെൻറ്റിലേറ്റർ അവിടെ വെച്ച് സ്റ്റോപ്പ് ചെയ്യും. വി ഹാവ് സീൻ ദാറ്റ് ഇഫ് എ ടൈഡൽ വോളിയം ഈസ് സെറ്റ്, ഈവൻ ഇഫ് ദ ടൈഡൽ വോളിയം ഈസ് പ്രീ സെറ്റ്, ദ പ്രഷർ in the airway increases means the tidal volume, that complete tidal volume will not be delivered to the patient. അപ്പോൾ ഇവിടെ വരുന്നത് എന്താണെന്ന് വെച്ചാൽ പേഷ്യൻറ്റിൻ്റെ ആഡിക്വേറ്റ് ആയിട്ടുള്ള ടൈഡൽ വോളിയം ഓർ വോളിയം ഓഫ് എയർ വിൽ നോട്ട് ബി ഡെലിവേർഡ് ടു ദ പേഷ്യൻറ്റ്. ആഡിക്വേറ്റ് ആയിട്ടുള്ള ഒരു എയർ സപ്ലൈ പേഷ്യൻറ്റിന് ഇവിടെ കിട്ടില്ല. And the patient gives, the ventilator gives high pressure alarm. Next one is assist controlled ventilation. The assist controlled mode is similar to CMV, but it allows the patient to trigger an assisted breath at any time. ഇപ്പോൾ ഇവിടെ അസിസ്റ്റ് കൺട്രോൾ മോഡിലുള്ള ഡിഫറൻസ് എന്ന് പറയുന്നത് CMVയിൽ പേഷ്യൻറ്റിന് യാതൊരു കൺസിഡറേഷനും ഇല്ല, പക്ഷേ അസിസ്റ്റ് കൺട്രോൾ മോഡിൽ പേഷ്യൻറ്റ് ക്യാൻ ടേക്ക് ബ്രെത്ത്. Assist control delivers a preset volume at a preset rate and preset flow rate in response to the patient's own inspiratory effort, but will initiate the breath if the patient does not do so within the set amount of time. ഇവിടെ ഒരു പ്രീസെറ്റ് വോളിയം ഫ്ലോ റേറ്റ് ആൻഡ് റേറ്റ് വിൽ ബി സെറ്റ്. ഓക്കെ, അതൊക്കെ സെറ്റ് ചെയ്തിട്ടുണ്ടാവും. പക്ഷേ പേഷ്യൻ്റ് എഫേർട്ട് എടുക്കുകയാണെങ്കിൽ അത് സെൻസ് ചെയ്തിട്ട് പേഷ്യൻറ്റിന് വോളിയം പേഷ്യൻ്റ് എടുക്കാനുള്ള ഒരു ഫ്രീഡം, ബ്രെത്ത് എടുക്കാനുള്ള ഒരു ഫ്രീഡം പേഷ്യൻറ്റിന് ഉണ്ടാവും. The patient cannot generate spontaneous volume or flow rates in this mode. All delivered breaths, whether mandatory or patient triggered, will be delivered by the ventilator according to the set parameters. That is, all breaths in assist control mode receive the same FiO2 and tidal volume. FiO2 എന്ന് പറയുന്ന ഫ്രാക്ഷൻ ഓഫ് ഇൻസ്പയർഡ് ഓക്സിജൻ ആണ്. അപ്പം നേരത്തെ സെറ്റ് ചെയ്ത് വെച്ചിരിക്കുന്ന FiO2 അതുപോലെ ടൈഡൽ വോളിയം, ഇത് രണ്ടും ആയിരിക്കും പേഷ്യൻ്റ് ഇനീഷ്യേറ്റ് ചെയ്യുന്ന ബ്രത്തിനും വെൻറ്റിലേറ്റർ ഡെലിവറി ചെയ്യുന്നത്. ഓക്കെ, അപ്പം പേഷ്യൻറ്റിന് ബ്രത്ത് ഇനീഷ്യേറ്റ് ചെയ്യാം. പേഷ്യൻ്റ് ഇനീഷ്യേറ്റ് ചെയ്യുന്ന ബ്രത്ത് വെൻറ്റിലേറ്റർ സെൻസ് ചെയ്യുകയും ദെൻ the ventilator will be delivering the preset tidal volume with the preset oxygen concentration. Actually, patient is not given a freedom of a spontaneous respiration. If a freedom is given here, or if the patient is permitted to take breath, means patient the tidal volume and the FiO2 also both should be according to the patient's condition or the patient's effort. But here the patient can initiate breath, but that will be sensed by the ventilator and the ventilator delivers preset tidal volume. Hyperventilation and respiratory alkalosis may result from occurrences that increase the patient's spontaneous rate, such as anxiety or neurologic factors. the minimum number of full ventilator breaths the patient will receive. The actual respiratory rate is equal to the assessed control rate plus any patient's triggered breaths per minute. This mode is used for patients who can initiate a breath but who have weakened respiratory muscles. അപ്പോൾ ഇവിടെ അസിസ്റ്റ് കൺട്രോൾഡ് മോഡ് എന്ന് പറയുമ്പം ഹൈപ്പർ വെന്റിലേഷൻ ആൻഡ് റെസ്പിറേറ്ററി ആൽക്കലോസിസ് ഈസ് എ മോസ്റ്റ് ഇമ്പോർട്ടൻറ്റ് കോംപ്ലിക്കേഷൻ ബിക്കോസ് ഇഫ് ദ പേഷ്യൻറ്റ് ടേക്സ് മോർ initiativeness or the respiratory rate of the normal respiratory rate of the patient is increased in conditions like anxiety or neurological conditions. If some neurological factor stimulates breathing, in such conditions the respiratory rate will be increased. So even if the patient's respiratory rate is increased, the preset rate is maintained in the ventilator. The patient it will be a total of the preset rate and the patient initiated breaths, which means മെക്കാനിക്കൽ വെന്റിലേറ്ററിൽ നമ്മൾ സെറ്റ് ചെയ്തിട്ടുള്ള റെസ്പിറേറ്ററി റേറ്റ് അത് അതേപോലെ പേഷ്യൻറ്റിന് കിട്ടും. അലോങ് വിത്ത് ദാറ്റ് പേഷ്യൻറ്റിൻ്റെ എഫേർട്ട് അത് ഓരോന്നും പേഷ്യൻറ്റിന് കിട്ടും. അത് സെൻസ് ചെയ്ത് പേഷ്യൻറ്റിൻ്റെ ബ്രെത്ത് വെന്റിലേറ്റർ സെൻസ് ചെയ്ത് അതുകൂടെ പേഷ്യൻറ്റിന് ഡെലിവറി ചെയ്യും. വിച്ച് മീൻസ് the respiratory rate will be increased. Okay, അപ്പം നമ്മൾ കോൺസ്റ്റൻ്റ് ആയിട്ട് we have to monitor the patient. Otherwise what will happen is that the ventilator will deliver the preset rate and the patient's respiratory breaths also, patient's initiated breath also will be delivered by the ventilator. Together the patient will go to hyperventilation or tachypnea, we can say. അപ്പോൾ അത് രണ്ടും കൂടെ വരുമ്പം പേഷ്യൻറ്റിന് കിട്ടുന്ന ടൈഡൽ വോളിയം ആൻഡ് റെസ്പിറേറ്ററി റേറ്റ് വിൽ ബി ഇൻക്രീസ്ഡ് and the patient can go to respiratory alkalosis. Okay, hyperventilation ഇപ്പോൾ respiratory alkalosis ഇപ്പോൾ at the same time if the patient accordingly what we do if the patient is going to hyperventilation we have to reduce the ventilator rate. ഇപ്പം if we are setting 16 breaths ventilator breaths then a patient is taking 10 breaths means the total respiratory rate will be 26. So at that time what we will do is we will reduce the respiratory rate to 6 so that the total respiratory rate will be 16. Okay, and if the patient fails to initiate a breath, what will happen? That respiratory rate will be decreased, and if the patient is taking only 2 or 3 breaths then that will a total of only 9 breaths per minute will be delivered to the patient, which means the patient will go to hypoventilation. That is the problem with this assist controlled ventilation. Okay, this is used in patients who can initiate a breath but who have weakened respiratory muscles. So the assistance will be provided by the ventilator. So this is the diagram showing assist controlled mode. You can see here patient assisted breath when the this patient's initiated breath with the ventilator will deliver the preset tidal volume, and the second one is the ventilator initiated breath. Okay, next is intermittent mandatory ventilation. It is most commonly used mode of ventilation. In this mode, the ventilator delivers a preset rate, tidal volume or inspiratory pressure and FiO2. The patient may also draw spontaneous breaths in between mandatory breaths. Unlike assist control, breaths that the patient takes spontaneously do not trigger or cycle the ventilator. Patient initiated breaths are completely spontaneous, neither assisted nor supported by the ventilator. Here the preset rate and tidal volume and FiO2 will be delivered to the patient. Along with that, patient can take patient's own breaths. Patient can initiate spontaneous breaths that will be sensed by the ventilator, but ventilator will not deliver the set tidal volume. So patient's each breath will be of patient's own with the what patient's own tidal volume and flow rate. Then this is the picture. You can see here uh, the ventilator initiated breath and the small one is patient initiated breaths. So hope you understood the difference between assist controlled mode and intermittent mandatory ventilation. So next one is synchronous or synchronized intermittent mandatory ventilation, that is SIMV. It was developed as a result of the problem of high respiratory rates associated with the assist control mode. SIMV delivers a preset volume or pressure and rate while allowing the patient to breathe spontaneously in between ventilator breaths. Each ventilator breath is delivered in synchrony with the patient's breaths, so ventilator patient fight will not be there, yet the patient is allowed to completely control the spontaneous breath. Okay, here an assistance is provided. If the patient fails to take a spontaneous breath, then at the set time the ventilator will deliver the breath. If the patient is taking the breath, then the ventilator will allow the patient to take spontaneous breaths. SIMV allows the patient to generate spontaneous breath volume and flow rates between the set breaths. SIMV is used as a primary mode of ventilation as well as a weaning mode. Weaning means extubation. We are planning to extubate the patient. So before that we have to make sure that the patient will not go to hypoxia even if we switch off the ventilator. So gradually we are taking off the ventilator. That is weaning. During weaning, the preset rate is gradually reduced, allowing the patient to slowly regain breathing on his or her own. So all of a sudden, from controlled mandatory mode, that is in which the ventilator controls the complete respiration or inspiration, we cannot take off the patient suddenly from CMV mode. So gradually we have to change it to SIMV, and then from there to pressure support, and slowly we have to take off the ventilator or stop ventilator. This is the SIMV mode. You can see the ventilator delivered breaths and a patient spontaneous respiration. Okay. So the advantages of this synchronized intermittent mandatory ventilation, that it maintains respiratory muscle strength by avoiding muscle atrophy, because the patient can generate breathing, patient can take initiate breathing, then decreases mean airway pressure, facilitates ventilator discontinuation, that is weaning, decreased chance of hyperventilation, decreased atrophy of accessory muscles, and improved distribution of gas throughout lungs by the action of the diaphragm. Disadvantages: this mode may increase the work of breathing and respiratory muscle fatigue. In intermittent mandatory ventilatory mode, the mechanical rate and spontaneous rate may asynchronous, causing stalking, and they may cause barotrauma or volley if it comes together. If it comes together, then more volume will be that patient's on effort as well as ventilator delivered tidal volume, both will be entering to the alveoli, and this can cause complications. Then the next one is PEEP, that is positive end expiratory pressure. It's not a separate independent mode, but this is given as a support. According to its purest definition, the term PEEP is defined as positive pressure at the end of exhalation during either spontaneous breathing or mechanical ventilation. The patient is also receiving mandatory breaths from the ventilator. One method of improving the patient's oxygenation without increasing the FiO2 is the use of PEEP. PEEP does not allow airway pressure to return to zero at the end of expiration. So what is PEEP? It is it's a positive pressure at the end of the exhalation. Okay, expiration phase end normally the alveoli collapse. But here if we set PEEP, then alveoli will not collapse at the end of expiration. So at the end of expiration also a minimum positive pressure will be maintained in the alveoli to avoid the collapse, so that the next phase, next inspiration will be comparatively easier. PEEP of 5 centimeter of water pressure is referred to as physiologic PEEP because it is equivalent to the effect of the closed glottis, that is the pressure maintained when the glottis is closed. Therapeutic PEEP usually ranges from 10 to 30 centimeter of water in adults. PEEP we have seen in ARDS. ARDS we have to increase the PEEP. PEEP is an effective therapy for disease process involving atelectasis. It is a cornerstone of therapy for ARDS. Disadvantages: this can lead to many complications because in the chest a negative pressure is created at the end of expiration. Just before the next cycle of respiration, a negative pressure is created. Okay, this will help in decreasing the thoracic pressure and also in increasing the cardiac output, or that aids in cardiac contraction and pumping of heart. Here when there is a constant increase in pressure in the thoracic cavity, that can decrease cardiac output with or without hypotension. It occurs because PEEP increases intrathoracic pressure. Then antibarotrauma, then increased intracranial pressure and potential loss of tidal volume. These are the complications or disadvantage of PEEP. So we should not increase PEEP unless and until indicated. So that should be kept at a minimum level. Then the next one is CPAP, that is continuous positive airway pressure. In PEEP, only at the end of expiration the pressure will be, there will be a positive pressure, but here in CPAP there is a continuous positive airway pressure. The effect of CPAP is compared to inflating a balloon but not letting it completely deflate before inflating it again. The second inflation is easier to perform because resistance is decreased. A continuous level of elevated pressure is provided through the patient's circuit to maintain adequate oxygenation, decrease the work of breathing. And CPAP may be used invasively through an endotracheal tube or tracheostomy, or non-invasively with a face mask or a nasal prongs. Okay. Then next one, it's not very frequently used mode, but it is also used, that is inverse ratio ventilation. Inverse ratio ventilation, IRV. The normal inspiratory expiratory ratio is 1:2, but this is reversed during IRV to 2:1 or greater. So here normally we know the inspiratory time is less when compared to expiratory time, that is 1:2. Here in IRV it is reversed, that is 2:1. 2 inspiratory time and 1 expiratory time. The maximum it can be increased to 4:1. This method is used for patients who are still hypoxic even with the use of PEEP. Longer inspiratory time increases the amount of air in the lungs at the end of expiration and improves oxygenation by re-expanding collapsed alveoli. The shorter expiratory time prevents the alveoli from collapsing again. This method requires sedation and therapeutic paralysis because it is very uncomfortable for the patient. Then time cycled ventilators we have seen in case of neonates or newborns and infants. Time cycled ventilators are used. Then initiating mechanical ventilation, that is the initial ventilator setting. First and foremost one is to select the mode, and according to the mode we have to select all other parameters. The initial the settings or the parameters on ventilator are frequency. Frequency means respiratory rate, that is 4 to 20 breaths per minute we can keep. Then volume, it is represented as VT. that is 5 to 15 ml per kg is the limit. Then FiO2 21% to 100%. 21% is the fraction of oxygen in the atmosphere, and we can go up to 100, that is the limit. Then inspiratory expiratory ratio, usually 1:2, that we have seen. Then flow rate is 40 to 100 liter per minute. Sensitivity or trigger is 0.5 to 1.5 centimeter of water. Okay, then PEEP usually 5 to 20 centimeter. What we have to keep is 10 to 20 if needed. These settings should be titrated against the patient's clinical state and level of comfort. We'll see each one. Respiratory rate, that is the frequency. F, it is represented in ventilator as F. The respiratory rate is the number of breaths the ventilator delivers to the patient each time. The rate chosen depends on the tidal volume, the type of the pulmonary pathology, and the patient's target PaCO2, that is partial pressure of carbon dioxide in the blood. The respiratory rate parameters are set above and below this number, and the alarm will then sound if the patient's actual rate is outside of the desired range. So in all these parameters, we have to set the upper limit and lower limit, and if it exceeds the upper limit, or if it goes down, also the ventilator will give alarm. Next is the tidal volume. You know what is tidal volume? It is a volume of gas the ventilator delivers to the patient with each breath. The tidal volume parameters are set above. This also should be set above and below, and the alarm will sound if the patient's tidal volume is outside the desired limit. Then the fraction of inspired oxygen, we have seen the what is it? That is the amount of oxygen delivered to the patient. Then inspiratory expiratory ratio. Then pressure limit. Pressure limit regulates the amount of pressure the volume cycled ventilator can generate to deliver the preset tidal volume. Because high pressure can cause lung injury, it is recommended that the plateau pressure not exceed 35 centimeter of water. Then flow rate, it is the speed with which the tidal volume is delivered, usually 40 to 100 liter per minute. Then sensitivity or trigger, the sensitivity determines the amount of effort required by the patient to initiate inspiration. This comes in intermittent mandatory ventilation or SIMV, because here if the patient initiates a breath, that triggers the ventilator to deliver the breath, or the ventilator withholds its breath. So that is sensitivity or trigger. Then sigh, the ventilator can be programmed to deliver an occasional sigh with a larger tidal volume. In between, we have to set sigh after how many breaths this sigh has to be given, or increased large tidal volume has to be administered to the patient. That also we can set. These are the parameters that we have to set in a ventilator. We will see the limits once again, that is frequency, respiratory rate 4 to 20 breaths per minute. Usually what we do is 12 breaths per minute, that is a normal. 12 to 16 we have to set, that is according to the patient's response. Then tidal volume 5 to 15 ml per kg body weight. Normally what we usually keep is 10 per kg body weight, which means for an average weight, that is 50 kg patient, 500 tidal volume should be kept. Then FiO2 21% to 100%. It depends on how it has to be set. That is 60 to 100% we can keep according to the ABG value. Then inspiratory expiratory time 1:2. Then the other things as given in this, and PEEP 3 to 5 PEEP we can keep, that is a physiological PEEP. Then according to the patient's condition we can increase. In case of ARDS, that is acute respiratory distress syndrome, we have to increase PEEP. It can be increased to 12, usually 10 to 12 will be kept. Then next is the indications for intubation that we have seen in the last class. How the value strength should significantly impact clinical decision. It is criteria: clinical deterioration, then tachypnea, that is more than 35 breaths per minute, hypoxia, PaO2 less than 60 mm of Hg, then hypercapnia, that is increased carbon dioxide level more than 55 mm of Hg, then minute ventilation, that is which is calculated by multiplying tidal volume with the respiratory rate, it is less than 10 liter per minute, then tidal volume less than 5 to 10 ml per kg, and a negative inspiratory force less than 25 centimeter of water. How strong the patient can suck in, that is negative inspiratory force. Initial ventilator setting I have already discussed, FiO2 50 to 60%, and definitely it depends on the patient's condition. If suction has to be done, we have to increase it to 100%, then remove the ventilator and do the suctioning of the endotracheal tube or tracheostomy tube. Then PEEP 5 centimeter, that is normal. Normally we keep 5. Then respiratory rate 12 to 15, tidal volume 10 to 12. Then ventilator alarms. Alarm, that is high pressure. Definition, that is pressure required to ventilate exceeds preset pressure. Potential causes: pneumothorax, excessive secretions, decreased lung compliance. Then low pressure, then low pressure alarm will be given, then low exhaled volume, rate or apnea, and FiO2. These are the usual alarm settings, alarms given.